Now we will have a presentation from another sociologist. The second speaker of today is a young and very talented colleague of mine, Henriette Lauvhaug Nybakke. Henriette is a PhD candidate at the Norwegian Centre of e-health research. The topic of her PhD is electronic medicine management. But you will not present your PhD project today, rather your master thesis. Henriette, I really look forward to hearing what you're going to present today. The floor is yours.
Thank you so much. Hello, everyone. I'm so happy to be here for the open days with the topic Digital Divide. My name is Henriette Lauvhaug Nybakke, and I'm doing this presentation with the title Social Inequality and Telemedicine. First, a little bit about me. I'm a PhD candidate at the Norwegian Centre for e-health research and UiT, the Arctic University of Norway. I have worked at the center since March 2021, first as an advisor and then as a PhD student. I have a master's degree in sociology with specialization in medical sociology. And that is what I'm presenting for you today, my master thesis. The primary themes of my master's thesis was digitalization and social inequality in healthcare. My main research question was, what impact can increased digitalization have on social inequality in healthcare? This is, of course, a huge question to answer, so I focused on the case of digital home care follow-up treatment to narrow it. So, what did we know about this topic? Well, we know more today than we did when I delivered this master's thesis in 2020. COVID-19 increased the need for digital solutions, and with that, more attention to the digital divide. A lot of people lack access to digital solutions, while others lack the skills and knowledge, and some both. It is also important to remember that someone can with ease use Snapchat or Instagram and still have troubles using other kinds of applications, especially within healthcare. People can have skills and motivations in some areas and then at the same time not in others. There's also been more attention to e-health literacy or digital health literacy, especially in Norway the last years. It was published a report on this last year, and we know that e-health literacy is related to gender, age, and educational background, and that individuals with chronic illnesses and lower levels of education tend to have weaker skills in using digital healthcare services. Even though we like to consider ourselves as equal in Norway, we do have social health inequalities as well. These are health disparities that are socially created based on various causes and reasons within our society. The positive aspect is that something can potentially be done about them. We still don't know enough about the causes and how social health inequalities are created. But we do have some knowledge, and there are work being done on decreasing health inequalities. We especially see the impact of social health inequalities in terms of mortality and life expectancy. We observe it in morbidity, knowing that some diagnoses, such as COPD, are unevenly distributed in the population. We also see it in subjective health measures, which refers to individuals' own assessments of their mental and physical health. We also know that health conditions vary with education and other socioeconomic factors, such as material factors, health behavior, and psychosocial factors. In other words, the better the socioeconomic status, the better the health. However, we also know that this cannot necessarily explain everything, and we need more information about other factors that may influence our health. There is also a difference in the use of healthcare services among different social groups. Those with higher education navigate the healthcare system and its various services more effectively. They know better what to ask for and how to approach healthcare providers. This is also related to the ability to articulate one's own health status and having the language for it. Here, we can also draw connections to different cultural backgrounds. For example, we know that some with a Sami background have a different language for illness and a different way of communicating about illness. Unfortunately, we still know little about this. Social health inequalities are also related to social demographic factors, such as where one lives, which can produce and sustain social health disparities. There can be several explanations for this, such as people with similar socioeconomic status tend to settle in the same areas. It also varies with housing conditions, whether one lives in a rented or owned property. There are underlying factors here as well, linked to economics and educational level. The existence of social health inequalities has a significant consequence for the society and represents a socioeconomic problem. For example, this leads to people who could have been in the workforce for a longer time not being able to work, which places an economic burden on society. There has been a significant focus on income, upbringing, education, and employment, which are known as social health determinants, as well as health habits and marginalized groups when explaining social health inequalities. Government interventions have also targeted these areas to reduce social inequalities. However, based on statistics, the disparities are increasing despite efforts, suggesting the need for new approaches, and it may be time to explore alternative explanations, especially when looking at the digital divide and its complexity. There is a significant focus on digitalizing the healthcare system, with the aim of solving many of the problems it faces. These issues include improving collaboration and communication across different levels of care, optimizing resource utilization and finances, and ensuring a safer and more holistic experience for patients. Some of the proposed solutions include moving as many healthcare services as possible to the patient's home, such as digital home care follow-up. There is an intention to increase the use of video consultations and e-consultations. We saw a significant boost in the use during the COVID-19 pandemic when there were simply no other alternatives. Patient records are expected to be electronic and accessible to those who need them. A digital medication list is also in development, which will provide patients with access to their medication information available to anyone who requires it in the healthcare sector. This field is rapidly evolving, ultimately benefiting patients by providing them with increased control. Patients will have insight into what doctors write in their records, be able to stay at home instead of at the hospital, and have full awareness of their medications. At the same time, our authorities working toward reducing social inequalities in healthcare and bridging the digital divide. And it is important to consider those who might not benefit from the healthcare becoming more digitalized. There was limited opportunities for data collection during the pandemic. I did a document analysis of 19 newspaper articles, 5 reports from projects on digital home care follow-up, and 2 reports to the Storting. That resulted in 6 patient types or categories after the analysis, which I have tried to translate from Norwegian to English. So the first one is the right patient, or you can call it the correct patient, the demanding consumer patient, the social patient, the rural and urban patient, the linguistic minority patient, and the vulnerable patient. And I will elaborate on some of these categories. The right or the correct patient. This category is based on the selected patients for the projects. The patients that were included in projects had to fulfill the inclusion criteria, which were that they had to live in the municipality, they had to be diagnosed with COPD and/or heart problems, adequate cognitive abilities, they had to have 4G or good internet connection, able to use the technology or ability to learn how to use the technology, and they had to be motivated. These inclusion criteria make sure that project participants most likely will be able to use the technology. But it is perhaps not representable when the technology is going to be used in everyday life. It is also a paradox that some of these inclusion criteria exclude the patients that are considered the future target groups and end users of these technologies. When including more representative participants, we can explore all the factors and challenges immediately, and then we can fix it. In addition, we know that based on previous research, that social factors can influence their abilities to use the technology or how motivated they are. In this category, I look into the future, the demanding consumer patient. It is how we expect our future elderly patients to be and behave. It is named the demanding consumer patients because we expect the future elderly to act as consumers in the healthcare service, and that health is a kind of item you can buy, which they will demand. They will have another type of health behavior as a consequence of higher education, better living conditions, and improved economy. However, the inequality and differences will increase. The resources will be unevenly distributed. There will be a bigger gap in digital literacy. We can't make technology that is only for the demanding future patient. And also, how correct is this view on future patients? Our society is always changing, and we have faced a lot of challenges in the last years. This category is named the rural and urban patient, but I will focus on the rural. Where people live affects the access to digital resources. There is still a need for improved digital infrastructure in rural areas in Norway. This is also the patient group that is one of the target groups of digital home follow-up treatment. If the internet fails during a Netflix episode, the consequences is not that major. But it's something else when it comes to health. In addition, it affects the trust and willingness to use the technology. They usually have access to internet. The problem is the quality of it. We also know that where people live often reflects their socioeconomic background, that these areas often have less people with higher education. We also have an issue in Norway that the young people move from the rural areas to the urban areas, often exactly for higher education. But they usually end up staying in the urban areas and not moving back. And then there's an imbalance, also age-wise, in the rural areas. However, the pandemic has kind of changed this trend, and more young people are moving back to the rural areas. Language and culture can be barriers to implementation of digital solutions. Culture affects the way we communicate, which can lead to misunderstandings and unintended discrimination. This is something we must be aware of when creating and using technology for monitoring and communication within the healthcare sector. But technology can also be a solution. For example, that you can get a doctor that understands your language and culture across the distances. Technology and health are two fields that have their own kind of language, which can be a barrier when people are using the technology or when they are learning to use the technology. So it is important to understand and assess the knowledge level. User involvement can also help to understand how we can make guides and how to teach usage of technology. So in conclusion, we need more research on social inequality and digital exclusion. It is complex and it's always changing. The reason and the way that people are digitally excluded can vary from situation to situation, or it can be more structural and changed over years. For example, in the 90s, it was more about owning digital equipment, and then it turned to lack of internet access. And today, we know that there are several reasons, but a lot of research shows that it's mainly about usage. We should include a variety of participants in research because the findings should reflect the problem and solutions when it is implemented. It is important to include users in research projects and in the development of digital health services.